Hello everyone, I'm Niharika, McMaster Radiology resident. In this video I cover the basics of degenerative versus inflammatory arthropathies. The objectives of this lecture are to understand the importance of correlating clinical and radiographic findings to diagnose different arthropathies, to recognize the key radiographic features of degenerative versus inflammatory arthropathies, and lastly, to recognize the skeletal distribution of common arthropathies. Before starting to review the radiographic images, it's very important to be aware of the patient's demographics. You should have a basic idea of the patient's history and the physical examination, including the symptoms that they present with, as well as the overall distribution. This information is key to making the correct diagnosis because an acute monoarticular joint arthropathy, for example, may be very different from someone who is presenting with a gradual onset of swelling and pain, which presents in a symmetric distribution. It can also be important to know about any key ancillary findings which may be associated with certain types of arthropathies. So, for example, rashes, which may be associated with psoriatic arthritis. Laboratory and pathology analysis can also provide useful clues to reaching the correct diagnosis. A good checklist to have in your mind while assessing radiographs for arthropathies is to look at the joint space, the associated bone changes, look at the surrounding soft tissues, the overall bone alignment, and to look at the overall skeletal distribution. Now this slide uses some terms that I will define as they come up while reviewing certain entities throughout our presentation, but let's just provide a quick overview and break these categories down further. So first, looking at the joint space, which is almost always joint space loss in the setting of arthritis. This may be symmetric or asymmetric, and there may be evidence of ankylosis. The associated bone changes may be destructive or proliferative. So we have to look at the overall bone density, look at whether there is osteophyte formation, evidence of erosions, whether there are any subchondral changes in terms of cysts and sclerosis. Look at the surrounding soft tissues, which may demonstrate swelling or calcifications. Assess the overall alignment of the joint. Some arthropathies may demonstrate joint subluxation, which we will touch on later in the presentation. And then at the end, look at the skeletal distribution, whether it's a mono or polyarticular arthropathy, whether large or small joints are involved. Some common arthropathies that we will cover in this lecture are divided into degenerative versus inflammatory. Under the degenerative category, we will cover osteoarthritis, and under the inflammatory category, we will look at rheumatoid, psoriatic, reactive, and septic arthritis, as well as gout. First, let's talk about a very common entity, osteoarthritis, which is a degenerative arthropathy. The key features of osteoarthritis are cartilage degeneration or cartilage loss, which occurs in an asymmetric fashion. So for example, in the pelvic radiograph on this slide, there are degenerative changes of the left hip with joint space narrowing and superior migration of the femoral head, which is very commonly seen because biomechanically, this is the part of the joint that bears the most load. Other radiographic features seen here of osteoarthritis are marginal osteophytes, which are these spurs growing off the bone, subchondral sclerosis of the femoral head and the acetabulum, which is this thickening of the bone, as well as subchondral cysts, which are not clearly demonstrated on this radiograph. Here's the breakdown of osteoarthritis in the knee in terms of mild, moderate, and severe. In the mild category on the left of the slide, we see at least one marginal osteophyte, which is shown by this white arrow, plus minus some evidence of joint space narrowing, specifically at this medial aspect of the joint. In the moderate category, we see signs of definite joint space narrowing shown by these black arrows, and marginal osteophytes, again shown by the white arrows, as well as subchondral sclerosis, which is this thickening of the bone seen here. In the severe category, there is bone-to-bone contact shown at the medial aspect of the joint, and complete obliteration of the joint space, again seen here at the medial aspect of the knee. Note that there are definite marginal osteophytes as well, shown by these white arrows. These are useful images of the distribution of osteoarthritis in the hands and feet. In the hands, osteoarthritis is especially seen at the first CMC joint, the DIP and PIP joints. In the feet, osteoarthritis is especially seen in the first MTP joint as well as the TMT joints. In terms of large joints, knees and hips are commonly involved. Degenerative changes can also involve the spine, and some key features are shown on this sagittal CT image of the lumbar spine. There is multi-level disc degeneration with loss of disc height between different vertebral bodies. There is osteophyte formation at the anterior aspects of these vertebral bodies. There is end plate sclerosis, which again is this bone thickening noted here. There's multi-level disc protrusion, for example, at this level as well as this level, which is leading to varying levels of spinal canal stenosis in this case. Another feature that's not shown here specifically is degeneration of facet joints, which can lead to an entity called spondylolisthesis. That just means that a vertebral body on the top ends up slipping out of place on the vertebral body at the bottom, and this leads to overall malalignment. This brings us to the end of the section on degenerative arthropathy. Next, we'll discuss inflammatory arthropathies. The first inflammatory arthropathy we'll talk about is rheumatoid arthritis. Again, keeping our basic checklist in mind, let's look at the features of rheumatoid arthritis under the 5 different categories we discussed earlier. So joint space, associated bone changes, surrounding soft tissues, overall bone alignment, and skeletal distribution. Rheumatoid arthritis involves symmetric joint space narrowing in contrast with the asymmetric cartilage loss that we saw in osteoarthritis. There is bone destruction in the form of marginal erosions and periarticular osteopenia. Soft tissue swelling is common in rheumatoid arthritis, and there may be also associated synovial effusions. There is severe malalignment in the form of subluxation, which is most marked at the MCP joints with ulnar deviation. Also note here the involvement of the ulnar carpal articulation, which is commonly seen in rheumatoid arthritis. Rheumatoid arthritis is associated with tenosynovitis in the hands, which just means inflammatory changes of the tendons, and in the most severe cases, there can even be tendon rupture. So the 2 basic deformities that are shown here associated with rheumatoid arthritis are boutonniere and swan neck deformities. Boutonniere deformity involves the PIP to be in flexion and the DIP to be in extension, whereas the swan neck deformity involves the PIP in hyperextension and the DIP in flexion. Here's another useful image summarizing the distribution of rheumatoid arthritis in hands and feet. In the feet, the distribution is pretty similar to that of osteoarthritis. In the hands, the wrist, the MCP, the PIP joints are most commonly involved, and note that there is sparing of the DIPs in rheumatoid arthritis. Here's a radiograph of the pelvis showing rheumatoid arthritis of the hips. Note how both femoral heads have migrated in the axial direction with fairly concentric joint space narrowing. Now, in your mind, compare that to the superior migration of the femoral head and the asymmetrical distribution that we saw in osteoarthritis earlier in the presentation. In this radiograph, there is also severe osteoporosis and degenerative changes associated with the pubic symphysis. We also see some erosions in this area. This is also a typical finding of rheumatoid arthritis. A really important point of discussion in rheumatoid arthritis involving the spine is atlantoaxial instability. People with rheumatoid arthritis can get C1 and C2 pannus formation, which leads to ligamentous laxity. You will often see flexion, neutral, and extension views of the C-spine for assessment in these patients, And a lot of the times this is in context of pre-op assessment for patients who are about to undergo anesthesia, or it could be in the context of trauma. Normally, the anterior arch of C1 and the odontoid process of C2 should be about 2 millimeters apart, and this distance should stay the same whether the radiograph is taken in flexion, neutral, or extension. Here we see an abnormal example. On the right of the slide, I have zoomed it in so you can assess it easily. In flexion, the distance is at 10 millimeters, and in extension, it's the normal distance, which is 2 millimeters. But since the distance has changed in the flexion view, this means that there is intersegmental translation, which is considered a marker of instability. Now let's look at the next entity, which is psoriatic arthritis. As we work through this slide, please keep that basic checklist in the back of your mind. In psoriatic arthritis, there are asymmetric marginal erosions which are out of proportion to the amount of joint space narrowing. There is bone proliferation in the form of periostitis and enthesitis. Periostitis is new bone formation in response to abnormal stimulants, and I'm demonstrating that with the pointer here. Enthesitis is inflammation at the site of attachment of ligament or tendon to bone. Also note on the radiograph of the fingers here that there is diffuse soft tissue swelling, and it makes this finger look like it's in the shape of a sausage, hence the term sausage digit, which is associated with psoriatic arthritis. Remember we talked about correlating with clinical findings earlier, and in psoriatic arthritis there may be evidence of rashes on physical examination, but in some people the arthritis may precede skin changes. Here are a couple of radiographic signs which are classically associated with psoriatic arthritis, the mouse ear sign and the pencil in cup sign. The mouse ear sign involves the DIP joints and it's secondary to marginal erosions. And here, because of the degree of bone destruction, the joint takes the appearance of a pencil end cup, with one end of the joint forming the cup and the other forming a pencil that projects into the cup. Here's a summary of distribution of psoriatic arthritis in hands and feet. In the hands, it predominantly involves the DIPs, and contrast that with rheumatoid arthritis where DIPs are spared. In addition to the hands and feet, there's also involvement of the spine and sacroiliac joints. The larger joints are relatively spared in psoriatic arthritis. Reactive arthritis is an entity that follows an infection at a different site, commonly enteric or urogenital. A classic triad that is seen is arthritis, conjunctivitis, and urethritis, or cervicitis in women. This foot radiograph demonstrates enthesitis and erosions involving the posterior calcaneus at the site of Achilles tendon attachment. There's also evidence of sclerosis, which is this bone thickening here. The next entity is gout, which is associated with uric acid crystal deposition in joints. So clinical and biochemical correlation is important in order to check for uric acid levels. Gout can be a monoarticular or polyarticular arthropathy, and the images here show common distribution in the hands and feet. Classically, the first MTP joint is involved and is termed podagra. In gout, we see juxta-articular erosion. Here are the classic punched out or rat bite erosions of gout. Note that these erosions are anywhere around the joint, and that's why they're termed juxta-articular in comparison to the other inflammatory arthropathies where the erosions tend to be marginal. On these radiographs, we also see periarticular hyperdense soft tissue swelling, which is termed tophi. These are also associated with gout. The last entity we'll discuss in this lecture is septic arthritis. This is an inflammatory arthropathy caused by an intra-articular infection. In terms of the radiographic findings, the joint may look normal at the very early stage, but as time goes on, there might be a joint effusion, cartilage destruction and therefore joint space narrowing, bone destruction, etc. In the pelvic radiograph shown here, there is complete loss of the right superior femoral acetabular joint space. There is mild destruction of the superior aspect of the femoral head and the adjacent acetabulum, and medially we see there is joint space widening. Now, if you were given this radiograph without any clinical history, these features are pretty similar to the hip radiographs of osteoarthritis that we discussed earlier in this presentation. And this is why clinical history is key in differentiating between the different arthropathies. So to summarize, in this lecture we discussed the key radiographic features of degenerative versus inflammatory arthropathies. We differentiated between the skeletal distribution of common arthropathies and emphasized the importance of correlating clinical and radiographic findings to diagnose different arthropathies. Thank you for listening.